Welcome, everybody. I'm Dr. Jennifer Dearborn. I'm a stroke neurologist at BI Boston and BI Milton.
Hi, I'm Kailee Murphy. I'm a nurse at BI Milton and I run our stroke program.
So we're really happy that you're here today, and we wanted to keep this informal. We want to tell you a little bit about stroke, do some education about what a stroke is and how to recognize the signs of a stroke. But we also want to be available for any questions that you have. We can take this conversation any direction that would be most helpful for you guys. So we have probably about half the time a more formal presentation, and then we'll have a lot of time at the end to kind of have a more open discussion. And we can talk about anything. I can certainly talk if you don't have any questions, but if you do, that would make it more interesting and more interactive. So feel free to ask away, okay? And if anybody wanders in, that's fine too. So I'm going to let Kailee start, and she's going to tell you a little bit about stroke.
So to start off, we're going to talk about the human brain. So the brain is the central organ of our nervous system in the human body. It controls both your motory, so your physical, and your sensory functions of your body. It helps you receive and interpret different information from your senses, your eyes, ears, nose, and it's responsible for thinking, remembering, understanding, planning, reasoning, and problem solving. So lots of important things. It's also made up of billions of neurons, also known as brain cells, that communicate through pathways called synapses. Your brain reaches its maximum size by 18 years of age. It's constantly changing and adapting to new experiences and challenges. And despite its small size, it's the most complex organ in your body. Next, we'll talk about different kinds of strokes and what a stroke is. So a stroke is a disease that affects the arteries of the brain. It can occur when a blood vessel bringing blood to the brain gets blocked or it ruptures. And the affected part of your brain, because of that blockage or rupture, doesn't get the oxygen and nutrients that it needs, causing that portion of your brain to die. So a brain injury from an acute stroke can affect any of your functions, like your ability to move, feel, think, behave. And a stroke is a medical emergency. Immediate treatment can minimize your long-term effects and even prevent death. So some stroke facts. Stroke, also known as a brain attack, is more common after age 55, but can happen at any age. I feel like we're seeing them a lot more frequently in younger people as time goes on. Stroke is the leading cause of disability. More than 2/3 of adults who have strokes will have a lasting disability. Every 40 seconds, someone in the United States has a stroke. And when you are having a stroke, 2 million brain cells die every minute. So we always say time equals brain. So the faster you move, the more brain cells you're saving. How common is a stroke? So these are facts for the US. So stroke has a large impact on society with more than 9 million stroke survivors in the United States. Every year, about 800,000 people have a stroke, and 185,000 about of those are recurrent strokes. So someone who had a stroke in the past having another stroke. Stroke is the 5th leading cause of death overall in the United States. It's the 3rd leading cause of death in women. About 55,000 more women than men each year have a stroke. Black people are twice as likely as any other racial group to have a first-time stroke. And treatment may reduce the effects of stroke if administered soon after the onset of symptoms. So like we said, time is brain. And up to 80% of strokes can be prevented with lifestyle changes. So a little bit later we'll talk about preventable and non-preventable risk factors. So there are a lot of things that you can do to reduce your risk of stroke.
I'll just highlight one thing, which is that stroke used to be one of the leading causes of mortality in the US, and now with our modern medical therapy, it's still a leading cause of disability, but more people are surviving a stroke. So that's been, we'll talk about some of the treatments that we have for stroke now, and that's been a success of the treatment pathways that we have. So stroke is a big term, and we're going to kind of subdivide that term into two main categories now. So the first is ischemic stroke. So the diagram here shows what happens in an ischemic stroke, that there's actually a clot that develops in the blood vessel. There could be many causes of that, but the concept is it blocks the artery that supplies the blood to that particular part of the brain. So that's the event that causes the death of the tissue that Kailee was referencing in the area of that blockage. So it's the most common type of stroke. It says 87%. We usually say about 80 to 90% of strokes are ischemic. And we'll talk about why that clot can develop in a little bit. And then the second subtype of stroke is hemorrhagic stroke. So hemorrhagic stroke, again, about 10% to 20% of all strokes that we see. And that's where you have a small blood vessel usually that breaks. And so then there's bleeding and actually a clot of blood that develops in the tissue of the brain. So the symptoms when someone has a stroke, you don't know if you're looking at the person if it's ischemic or hemorrhagic because they both can present with the same symptoms. So we really need brain imaging to help us tell the difference. And that's very important because we treat the two types of stroke differently. And then finally, there's a lot of confusion about what a TIA is, or a transient ischemic attack. Some people use the word mini stroke. Mini stroke doesn't really have a medical definition. That's just kind of what people say. But a transient ischemic attack is the correct terminology. So what that is usually a clot that develops in the brain. But then if the clot goes away, there's not any tissue injury or tissue death in the brain. So someone gets better. So a TIA is someone has the symptoms of a stroke, but it gets better. And for the definition, it has to be better within 24 hours. Okay? But practically, usually the symptoms get better within an hour or two. Okay? So that's what a TIA is. So the risk factors are the same as for ischemic stroke. It's just as important as ischemic stroke because it means the same process happened. But fortunately for the person, they didn't have any disability, deficits, or brain injury from it. So that's what a TIA is. So we treat TIA urgently, like usually in the emergency room in the hospital, because we know that people that have a TIA are much more likely to have an ischemic stroke in the next 30 days. So that's why we try to figure out why the person had the TIA so we can mitigate that risk factor to prevent that stroke that will come. So that's why it's called like a warning sign. Absolutely, yeah. So there are really two parts to your question. One, I'm going to sort of address a little bit further on the talk, which is what are the causes of ischemic stroke? Because there are many. As you mentioned, they can come from the heart. We've heard of carotid artery problems. There can be plaque. There can be what we call small vessel disease. So there's many things that can cause ischemic stroke, and we'll talk about how to prevent it. And then the second part of your question is can low oxygen, because we've talked about how the brain isn't getting enough oxygen because there's a blockage. So usually things like pulmonary disease or like a global loss of oxygen don't cause stroke. It doesn't mean that it can't affect the brain, but doesn't fall under this definition of stroke. So that it's not to say it doesn't affect the brain, it's just to say it's not the same process. Yes. So the lack of oxygen from the lungs is a little bit different than the process we're talking about here. The question is really, how does obesity play into stroke risk, and how does obesity play into stroke recovery? Is that the question? So obesity is a risk factor for stroke because it's associated with other things like high blood pressure and diabetes, high cholesterol that are also associated with stroke. So that is one of the things that, we counsel people to try to lose weight, to try to be active, to eat well, things like that. But in another way, obesity doesn't necessarily affect the stroke itself. So it's more related to the cause. Is that what you were asking? Yeah. Okay. So how stroke can affect you. So recognizing a stroke is probably one of the key things I want you to get from this talk, because if you can get to the hospital when the stroke symptoms start, if you don't stay home and say, oh, let me go rest and go to bed, there are now a lot of treatments that we can offer, but they're very time sensitive. So that's why recognizing the stroke is one of the most important things we want you to get from this talk. So this is kind of a busy slide, and it just summarizes all the things that the brain does, basically. But a stroke can obviously cause a lot of different presentations. But because the brain is involved in language, so the left hemisphere of the brain is involved in spoken language, people can have trouble talking when they have a stroke. People can have trouble with numbers and calculations. That's the left side of the brain. The right side of the brain is involved in spatial orientation. So there's a very interesting syndrome, I won't get too into it, but just to mention it in case you've seen it, called neglect. Have you ever heard of neglect? So people with right-sided strokes who have weakness on the left side of the body sometimes are not aware of the left side of space. So if they have their tray in front of them and they're eating the meal, they may only eat from the right side of the tray because they sort of lose that spatial awareness of the left side. Very severe neglect can get to the point where someone can't recognize their left arm. So that neglect syndrome is one example of one of the things that happens in the right hemisphere, along with many other. That's kind of our creative side of the brain. It's our musical side of the brain. It's not involved in language, but it's involved in some of our creativity, insight, awareness. That's where sometimes music therapy is a really great strategy to help someone who's recovering. So we're going to go through kind of, and you have it in front of you, you have the FAST algorithm. Okay, I'll let Kailee talk about the FAST algorithm. But before we get that, I just wanted to finish this concept of right versus left strokes. So we talked about languages on the left, and we talked about, and that's, and math is actually on the left, and on the right is more creative side of the brain, art, music, interpretation, interpreting emotion in people's voices, and also this neglect syndrome. But the most important thing that is visible is that a left-sided stroke causes weakness on what side? Right. The right side. Yeah, exactly. Everything's crossed in the brain, and a right-sided stroke would then cause weakness on the left. So that's the most visible. And sensory changes, too, would be crossed like that. So those are the most visible functions of the right and left side. Because the brain and the spinal cord also is kind of split, we do worry about symptoms that are on one side of the brain or the other. Now, numbness can be many things, but it is one of the warning signs of stroke as well, along with weakness. So we can talk in your particular circumstance if you like after, but just in a general sense, I'm going to have Kailee go through this. This was created by the American Heart Association so that you can recognize someone else that's having a stroke and you can remember it, in that moment, just to kind of help cue your memory. So I'll let Kailee take that away.
So yeah, it used to be just FAST, but recently they've added the B too. So it's an easy way to remember kind of the key things in trying to identify a stroke in someone else and what to do. So the B is for balance loss. So somebody might have a sudden loss of balance, coordination, trouble walking, they might feel dizzy. E is for eye or vision changes. So they might have blurred vision, double vision, they might lose their sight completely in one eye or both eyes. The F is for facial drooping. So if one side, like if you ask someone to smile and only one side of their face goes up, or maybe one side droops down, does your face feel numb? A is for arm weakness. So you would want to ask someone to try and hold like their arm up, and if it falls down, when they try to raise it, does it drift? Can they not move it at all? S is for speech. Is their speech slurred or difficult to understand? So you could like ask them to repeat like a simple, phrase like "see the dog run" or something that, you would clearly be able to understand. And if they sound like they're slurred or they don't sound like themselves, that would be a sign. And T is for time. So like we said, time is brain. So if you have any of those symptoms or you see someone having those symptoms, you want to call 911 immediately. So be fast is kind of the little thing we use to remember. So again, when you think you might be having a stroke or somebody else might be having a stroke, you really want to make sure you act quickly by calling 911. Your medical options may reduce the effects of your stroke, and as Dr. Dearborn said, time is super important because a lot of our treatment options are very time limited. So the quicker you act and get to the hospital, the more options you'll have for treatment. So at BID Milton, we are recognized by the American Heart Association by their Get With the Guidelines Stroke Gold Plus Award. The American Heart Association sets kind of the standard for stroke treatment, and we're graded based on how well we're adhering to those treatment recommendations. And they ensure that patients receive the most appropriate and timely stroke treatment based on all their research. So this is our stroke patient data for last year. So at Milton, we saw 257 stroke patients from January to December. 164 of those were ischemic stroke patients, 39 were hemorrhagic stroke patients, and 54 were TIA, or transient ischemic attack patients. We do sometimes have patients that need to go to a higher level of care. So some of these patients get admitted at Milton and treated there. Other ones we transfer into Boston, which I'll talk about in a second. So Milton is an acute stroke ready hospital, which means we are able to assess patients with imaging, and we can treat patients with a blocked vessel or an ischemic stroke using a clot busting drug called tenecteplase, or TNK, along with other therapies. For more complex stroke cases, we would transfer you to a comprehensive stroke center, which we partner with Beth Israel Deaconess Medical Center in Boston. They're our CSC partner. So if you needed additional treatment that we couldn't provide, we would transfer you there. So a comprehensive stroke center, they can do everything that we can do at Milton and more. So they would see ischemic and hemorrhagic stroke patients. They have 24/7 access to minimally invasive catheter procedures. Sometimes we can't bust a clot with the medication alone. You would need to have a procedure where they go in and remove the clot. And then they have neurological and neurosurgical services available for any procedures or anything you might need. So if you come to Milton and you think you might be having a stroke, again, it's important. We're going to say a lot of the same things over and over, really like hammer it home. If you think you're having a stroke, you want to go to the hospital right away. Like I said, you might be eligible for a clot busting medication. We use tenecteplase, TNK for short. So you'll be evaluated by the emergency room physician, potentially a neurologist. You'll probably have a CAT scan of your head to, like Dr. Dearborn talked about previously, to determine whether it's a bleeding kind of stroke or a blockage kind of stroke, because the TNK medication that we would give you is a clot busting medication. So it increases your risk of bleeding. So if you're having a bleeding stroke, we wouldn't want to give you that kind of medication because it's going to make it worse. So only ischemic or clot strokes get the medication. So you have to have imaging. And the TNK that we give has been shown to improve your 3-month functional outcomes in patients that receive it. And 1 in 8 patients who get the medication do have an improved recovery. But like I said, there are some risks for bleeding.
It sounds like a small number, but if you think about the number needed to treat for something like aspirin, it's like 320. So just to give, it is an effective treatment by all measures, but not everybody's going to get better because they got the medication. So, but medications generally have, you have to give it to many, many patients for one patient to benefit. Surgical procedures, for example, fixing somebody's carotid artery, you have to fix 15 people's carotid artery to prevent one stroke. So this medicine's even more effective than that. So it sounds not so effective, but in comparison to our other therapies, it actually is.
So again, when you come to the hospital, you'll get evaluated. Like I was saying before, if you have a clot, we refer to it as an LVO, or a large vessel occlusion. That would be potentially a candidate for a clot retrieval procedure called a mechanical thrombectomy. So those patients, sometimes they get the clot busting medication prior to having the surgery, sometimes they don't. And the mechanical thrombectomy would occur at a comprehensive stroke center, so BIDMC, with specialized physicians. So like we were talking about before, risk factors. So these are some of the risk factors that you just inherently have and there's nothing you can really do about it. So these are things you can't change and can't be controlled. So your age. While strokes, like we said, they can happen at any age, your risk does increase after 55. As well as your family history, strokes appear to have a genetic link. So you face a higher risk if you have an immediate family member who has had a stroke. Race and ethnicity, like I said before, Black people have a higher prevalence of stroke and a higher death rate from stroke than any other racial group. Also, sex, women have a lower risk than men before menopause, but more women than men die of stroke. And like we talked about, a prior stroke or a TIA inherently increases your risk of having another event. So a person who had a TIA has a 1 in 3 more likelihood of having a stroke in the future. And if you've had a stroke, you're at a greater risk for having another stroke. So almost 1 in 4 patients that have a stroke will experience a recurrence in the following 5 years. Medical risk factors, so high blood pressure is a huge risk factor for stroke. So anything over 120/80 is considered high blood pressure. You want to work with your primary care doctor to manage your blood pressure and talk to them because your numbers may be different for someone over age 65. Like your baseline that they want you at might be different, but that's kind of the general 120/80 is considered normal. As well as if you're a diabetic, diabetics have, it more than doubles your risk of stroke. So that's something we focus on a lot with stroke. High blood glucose increases the plaque buildup and it damages your arteries. So that plaque can come off and cause a clot in your brain. Other medical risk factors, cholesterol, a buildup of fatty deposits in your artery walls. Also that can break off and cause a clot. Circulation problems, strokes can be caused by blockages in your arteries and veins, like in different places of your body. And if that blockage comes loose, it can travel to your brain and cause a stroke in your brain, as well as a heart condition called AFib or atrial fibrillation. That also increases your risk of stroke 5-fold. And then lifestyle risk factors. So these are things that we can control to greatly reduce, I don't know about greatly, but significantly reduce our chance of stroke. So smoking and vaping, current smokers have a 2 to 4 times increased risk of stroke compared to non-smokers or people who have quit smoking more than 10 years ago. Alcohol use, heavy drinking can increase your risk for stroke. The recommendation is no more than 2 drinks a day for men and 1 drink a day for non-pregnant women. Increasing your physical activity can help reduce stroke, so even just a brisk 30-minute walk a day can improve your overall health as well as reduce your stroke risk. And as we talked about before, obesity and excessive weight gain can put a strain on your entire body, and that also increases your risk for stroke. You want to eat a healthy diet. Fresh fruit, vegetables, whole grains, include a variety of protein, leans, meats, fishes, beans, tofu. Minimize your processed food intake, your salt intake, your sugar, and try to avoid fried foods. And then just a couple more tips. You always want to take your medication as directed by your doctor. Trying to reduce your stress is helpful. It can contribute to different behaviors like overeating, lack of physical activity, unhealthy diet, smoking, drinking more than you should. And you always want to make sure you have regular checkups with your doctor and include assessment for your risk of stroke. And that's our presentation.
Thank you, Kailee. That's great. So now's kind of we can go in whatever direction you guys want to go in. So any comments or questions so far? So hemorrhagic stroke, we didn't really talk as much about the causes of that because Kailee highlighted a lot of the cardiovascular risk factors for ischemic stroke, but an aneurysm would be one cause of a hemorrhagic stroke. So an aneurysm is a weakening in the blood vessel wall that can then rupture and lead to something called a subarachnoid hemorrhage, bleeding in the brain. Yeah. So, but the other causes, we can talk about the causes of hemorrhagic stroke. The big cause is high blood pressure. So with high blood pressure, there can be a weakening in the blood vessels. High blood pressure cumulatively over time. So not necessarily in one moment, but over, say, 10 years. There can be weakening in the blood vessels to the point that one kind of ruptures and you have bleeding in the brain. So that's the largest risk factor for hemorrhagic stroke. And then as you get older, there are some conditions that we see in the brain. One of them, I don't expect you to remember this, but it's called amyloid angiopathy. Has anybody ever heard of that? Amyloid. It's a disease of aging where a protein called amyloid builds up in the blood vessels in the brain. It can be associated with some cognitive issues, but it's also associated with hemorrhagic stroke. So for somebody that has a certain type of hemorrhagic stroke, we might look for evidence of amyloid. So there are different causes. So, and that's why, of course, you're hooked up. If you've had a stroke, you should see a neurologist afterwards to help you really understand personally why your stroke happened, because there are many causes of both ischemic and hemorrhagic stroke. So physical activity is associated, increased physical activity is associated with a reduced risk of stroke. And physical activity can take many forms. It can be gardening, it can be house cleaning, it can be going on a walk, it can be riding your exercise bike. What are some other things?
Riding a bike outside,
what are some other
walking
things
your
you guys
dog.
do? Walking your dog. So it doesn't
hike.
have to be the traditional, I'm going to go to a class, which is wonderful, and I'm sure there's many classes offered here, and that's an easy way to get check off the exercise box. But if you have things that you do in your daily life where you're moving, it's the movement that seems to be important. More and more in our daily life, we're sedentary. That's just the way our society is structured now. We drive everywhere. We sit at a desk all day. So that's where the structured, I'm going to spend this hour going to class, doing exercise is very intentional and very helpful. But if you can structure your life so that you're moving around all day, that's also great. Blood pressure variability, okay? So blood pressure variability is a measure of how much someone's blood pressure changes over the course of 24 hours. And some people have high blood pressure variability and some people are relatively stable. So if you are someone that does have high blood pressure variability, you might benefit from something called ambulatory blood pressure monitoring, where we actually measure your blood pressure over 24 hours with a home cuff to understand what is your true blood pressure. And that's how you can guide therapy, because some people have normal blood pressure in the morning and it's very high at night. So we do worry about people who have just high blood pressure at night. We don't want to just take the lower number. So your doctor usually treats to kind of like your average blood pressure over 24 hours. So that's where understanding kind of where you are on average can be very helpful. If you can't do the 24-hour monitoring, just measuring your blood pressure at different times of the day can also give you that sense. I think that everybody has a different kind of blood pressure that their brain and their body is used to, that their blood pressure that they kind of live at. And as another example, there are some people that live with a very high blood pressure. Now, we just talked about reasons that we don't want that to be. But if someone's brain is used to seeing a blood pressure of 200 every day, we have to be very careful about how fast we lower it because their body's used to that. So the same with someone with low blood pressure. So the other point I want to highlight about that is something that Kailee brought up, which is that as you get older, your arteries get a little bit stiffer, a little bit harder. We call it arteriosclerosis. And so so we worry more about low blood pressure because your arteries can't adjust to that as well as when you were younger. So we try to avoid over-treating your blood pressure, because when you have low blood pressure, you can fall. You can get lightheaded, you can get dizzy. And falls are also something that we really want to avoid. We want the blood pressure to be normal, and we don't want it to be too low or too high. And we can't always get that like exactly perfect because people have variability. So that's sort of how your doctor approaches it. We want to tell you the message that you should take here is that if that Be Fast algorithm, balance, eyes, face, arm, speech, time, applies whether it's minor symptoms or major symptoms. Because the reality is a stroke starts somewhere, and sometimes it gets worse, and it can get worse quickly, right? So, and there are other treatments that we offer for a minor stroke in the emergency room other than the tenecteplase, which we don't always offer for minor stroke, by the way. but there are other treatments, other medications that we might give you. So the concept of time is brain, even if, say you just have, I have a lot of patients that say, my arm was a little clumsy, my hand was a little clumsy, my foot was dragging a little bit, I was able to get up and walk, and I just said, let's see if it goes away. And what we want to encourage people to do is to fight that urge, to call 911 and to get to the emergency room. And what calling 911 does is it adds a level of urgency to your arrival in the emergency room. You're triaged immediately as a stroke. You're taken right to the CT scanner. The team is right there. We call it a stroke code. So everything is kind of activated. Where you come in your car, you hope that process happens too, but there's not that pre-hospital notification by the EMS. So the teaching really is to call 911. You certainly, what you don't want to do, and I can't tell you how many times I hear this and it terrifies me, you don't want to drive yourself. There's a lot of other things that can cause each of those individual symptoms in the be fast. The key about stroke is the symptoms come on like this, okay? So the timing is one of the things that makes it emergency. The symptoms are not there and then they're there, okay? So that's one of the things that we want you to be aware of. Now, there are a lot of gray areas and maybe things that you're not so sure about. And so you should know that your primary care office or whatever doctor you work most closely with should always have a doctor or a nurse on call who can help you for something like, I don't really think this is a stroke. I've had this 12 times before, but what should I do about it? So then you can call and get some medical advice. So that's what I would recommend in that situation. So, and they can tell you which way to go. When somebody is young, we have different reasons that we think about stroke. So age is a risk factor for stroke, as we mentioned, and a lot of the conditions that cause stroke are associated with aging, like AFib. We haven't talked too much about AFib. I'm sure people might have questions about AFib. High blood pressure associated with age. So a lot of those conditions, that's why stroke is more common in people that are older. But for young people, we have different risk factors. For one, there's a rise in obesity in young people. So that means with a rise in things like diabetes, which can cause stroke in the young. But we also look for very specific conditions. For example, you might have heard of a PFO. People can have arterial problems like a dissection. There's a whole different cause of stroke in young people. But there's a lot of lifestyle risk factors that I think go into that shifting demographic of why we're seeing people at younger ages. There's something called the stroke belt, which is the area that it runs through the middle of the country, like a little bit in the south. So we're out of the stroke belt, so that's great for Boston. But in the south, there's a really increased prevalence of stroke in this area of the country that runs kind of like a stripe across the middle. And it's also a part of the country where there's high levels of obesity and poor diet and hypertension. So the stroke risk sort of mirrors a lot of those risk factors in that population. Everything for your personal health, you should definitely discuss with your physician because everything's a personalized recommendation. But a lot of the discussion kind of, should I take it, not take it, came that historically the advice or the thinking was, well, why not take it, right? Like it's just a baby aspirin and we know it thins your blood and that sounds like it's really good. And the thinking shifted a little bit when we saw more bleeding in people that were taking aspirin. So you should take aspirin if there's a reason to take aspirin. And that's what you should discuss with your primary care physician if there's a reason to, but it's not sort of a blanket recommendation at a certain age or something like that anymore, which used to be more common.
AFib, you have the different chambers of your heart. So your atrium, instead of kind of doing the typical like lub dub when your heart pumps, it kind of just quivers a little bit. It doesn't pump so great like it's supposed to. And every time your heart is pumping, it's leaving a little bit of residual blood in your heart instead of pumping it all out to the rest of your system. And the risk is over time that blood can kind of collect and it just sits there and it can form a clot. And then especially if you go from the rhythm of AFib back into what we call normal sinus rhythm, which is like the baseline you want your heart to be at, it could then push that clot out into the rest of your system, potentially causing a stroke. So usually people who have AFib, if it's appropriate, are on a blood thinner to kind of prevent that clot from forming, even though you're having a little bit of blood that's kind of still hanging around in there. That's probably not the best.
No, that was great.
Technical.
That was great. And I think that's one example of kind of why regular follow-up with medical care can also reduce your stroke risk, because you only know you have AFib if you went to the doctor and got an EKG. Not everybody has symptoms.
Yeah.
So if you feel palpitations, because not everybody with AFib feels palpitations, but if you do feel palpitations, it's definitely, it doesn't mean that you have AFib, it could be something else too, but it's something that you want to talk to your doctor about so that you could look into what the cause of the palpitations was. Just like, how do you approach going to the doctor's visit? Like I see a lot of people here that are already doing this. I think it's a really good strategy, and many of you probably already do this, just to take notes, because things may make sense when you're hearing them, and then you go home and you're kind of like, well, what were my risk factors for stroke? You know, what can I do to prevent it? So if you just take notes, I think that's really important. That's a great question, and it depends on the person's individual risk factors for stroke. I'll give an example that might be more easy to explain, which is someone might have AFib, which we already know is a risk factor for stroke. So if you're going to have elective surgery, you then need to stop your blood thinner. So that's one thing that is carefully considered in your perioperative planning. And the same for other medications that you might be on, like aspirin or blood pressure medications. But depending on the surgery itself causes stress on the body, and there's an increased risk, we know, of clotting when the body's under acute stress. So just in general, most surgical procedures that are major surgery, we know that they're associated with things like clots in the legs, which the hospital is very careful about trying to prevent, and other types of clots. So the risk of stroke for a particular surgery may not be high for everybody, but it's something that can be considered based on your individual risk factors. Yeah. So the question was, can we elaborate on something called factor 5? So I'm going to take that a little bit more broadly and say that we mentioned kind of common causes of stroke, AFib. I didn't really talk too much about carotid disease. I'm certainly happy to. Plaque in the arteries, small vessel disease. There's a whole other category that we call other that includes things like, do you have anything that makes your blood thicker? Anything that makes your blood clot more than other people, okay? So factor 5 Leiden is a genetic condition that can make your blood more likely to clot than other people. And actually factor 5 Leiden is not usually associated with stroke, it's associated with venous clots, believe it or not. So in a more complicated way, it can be associated with stroke if you have a connection in the right and left side of the heart, but in general it's not a stroke risk factor. But there are other clotting disorders that can affect your risk of stroke because they make the blood more likely to clot in the arteries. Cancer is another one. So we see a lot of cancer-associated stroke because there's certain types of cancer that can make your blood clot more than other people. Aneurysms, as you brought up earlier, can be a cause of hemorrhagic stroke, a specific kind of stroke called subarachnoid hemorrhage. And it depends. So certain types of aneurysms we think about running in families, and other types no. So we know that smoking is a risk factor for aneurysms, and high blood pressure is a risk factor for aneurysms, and age. So if we have a very young person with an aneurysm, we might be more likely to think about genetic risk factors. So, or if there's multiple aneurysms that someone has without those risk factors. So again, a lot of this care is specialized, and my colleagues in neurosurgery have a center where they follow patients very closely that have aneurysms and counsel them one-on-one about whether they should have intervention or not, because if you know about an aneurysm, there are techniques to coil or clip it if that's appropriate versus just surveil it over time. I usually recommend a one-time visit with a neurologist because it's really important to understand why the stroke happened. And sometimes, especially in the hospital, if there was a hospitalization associated with the stroke, not all the workup's back yet, and the picture isn't as clear as it is in the outpatient setting. So at least I think it's a good idea, at least for one time, to make sure that you've met with a specialist in that condition to guide what the management should be. And we do hand off a lot, like we work very collaboratively with the primary cares who manage a lot of these conditions long term, like the high blood pressure and the diabetes. And so our role is not to step on that. The primary care still does that, but just to highlight anything additional, like how much should we surveil the carotid artery, for example? Do we need to do imaging every year or not? Things like that. So that's an interesting question because it's changing nationwide now because there's actually these stroke mobile ambulances now, which we don't have in the greater Boston area, but maybe in the future we'll have, where they're mobile stroke units. So in the unit is that CAT scanner, the neurologist comes in video, and they have the ability to give this medicine in the field. So that's the future of stroke care. We're very excited for that, and there's certain regions of the country that are already implementing that. These ambulances, as you can understand, are very expensive, so they're not practical to have everywhere. But in our current ambulances, the people responding in the ambulance are trained to recognize stroke and to make sure that you get to the appropriate center for stroke. So for example, we talked a little bit about mechanical thrombectomy, which is in passing, that there's some catheter-based therapies that we can use for large vessel stroke, if someone's having a large vessel stroke. So our paramedics in the field are fairly accurate at identifying, based on someone's presentation, whether someone might have a large vessel stroke, and therefore getting them to the center that might be able to offer that therapy. So that's one thing. But for minor stroke, there's pre-hospital notification, there's assessment of the patient, and then kind of looking at things like the blood pressure that they can treat. But right now, we're not giving any of these clot-busting drugs or anything in our ambulances.
It's a lot of the stuff that's in like the Be Fast, they'll ask you to do. Like they're gonna ask you to smile so they can check your facial droop. They're gonna have you raise your arm. So to kind of assess how severe the symptom is.
Thank you guys for your interest.
Thank you so much.